Hello, welcome to this meeting. You will have hopefully heard the announcement that this meeting is being recorded. So hopefully nobody has any objections to that. It just means that we will be able to share the presentations and the recording afterwards for those people who couldn't make the seminar. I'm delighted to say I think we have about 71 people registered for this presentation today, which is on sort of the behavioural insights. And I'm really looking forward to a lively discussion. It's on the mobilisation of behavioural science in the time of COVID. What we're going to do is, I believe the Director General of RIVM wants to say a few words before we begin with our first speaker. But if people have questions and answers, we'll be using the Q&A box on Zoom. So if you can post your questions on that. I think we have the opportunity to allow speakers to come in, but we've only got an hour and we have quite a lot to get through. So I think it will probably be easier if we just post and then select questions and answers. And if we don't get everything covered within the necessary time, then we can post the questions to participants and hopefully get some responses to any outstanding questions after that. Should I, first of all, I don't know whether we've managed to find the unmute button for our sort of colleague from RIVM. Is that possible to just allow you to say a few words first?
Yeah, excellent. And I think I have found the unmute button, and now you would also probably want to see me. So I now also need to find the camera button, which is a little bit more difficult, I guess, in this. You're not seeing me, right?
We're not, but your voice is fine. So
well, and my voice might be enough. I'm at home anyway, so not dressed for the occasion. And I just wanted to express my gratitude for and my appreciation for organizing this meeting. I've seen that IANPHI has organized a series of meetings in this COVID-19 corona crisis. And I think we all realized very soon that managing this crisis is very largely dependent on what people do and what people don't do based on. So it's really focused on health behavior and precautionary behavior of the general population, as well as health professionals. And therefore, I think it's an excellent opportunity that today the French experiences and the Dutch experiences are shared within the larger IANPHI community. And I'm of course delighted to be able to announce my colleagues from RIVM who have very professionally and very swiftly organized a behavioral change and health behavior unit within our institute to address this important issue. And I would like to leave it by that and wish everybody a very inspiring and educating experience this afternoon. Thank you very much.
Oh, thank you, Hans. So actually, that's a good introduction to our colleagues from RIVM. So Marieke Leurs and Professor Marijn de Bruin, who will be speaking to us first of all. So I think it's a combined presentation. Which will last up to 20 minutes, then hopefully there'll be some time for some questions afterwards, which, as I say, if you could post on the Q&A session, I'll be monitoring those and we'll be able to ask some targeted questions. So over to you, Marieke, to talk about the theory-based rapid response work of the Dutch Corona Behavioural Unit.
Yes, thank you very much, Neil, and welcome everyone watching here. We're from Bilthoven at the moment. Me and Professor Marijn de Bruin. We will lead you through our first 3 months. And doing so, I'm handing over the first starting point with Marijn, because he was the first one involved and I joined later.
Can we get the slides on?
Oh, we had the slides on.
Nou, misschien.
No.
Nou, ietsje, denk ik. Yeah.
Yeah.
Okay, thank you very much. So we'll be talking a bit about sorry, can I do it? Yeah, thanks. And the process and the impact of the Corona Behavioural Unit. here in the Netherlands. It was sort of February, mid-March, when I was still a peaceful academic in my office, very quiet. And then I got involved in the government response to the corona pandemic. And since then, I feel sort of like a Sherlock Holmes in a marathon, completely exhausted, but very inspired and exciting. So the time that we got involved was when the curve of infections and ICU admissions was quite rapidly increasing. And in this time, myself and Rijntjan Renes, who's a professor at the University of Amsterdam, got in an advisory board of the National Core Team of Crisis Communication. And we were in that advisory board, and we noticed that we were seeing a lot of virologists and epidemiologists, while actually the virus is the problem, but behavior is the solution. So we started to have lots of discussions with policymakers and others to say, well, actually, we've got a very mature behavioral science as well, not only internationally, but also nationally in the Netherlands. Should we maybe activate that and make that accessible to government policy and communication? And that's how we got escalated to somebody at the level of Marieke Leurs, who we then met at the RIVM.
Yes, so we're talking 19th of March, and this was a week after the start of the intelligent lockdown in the Netherlands, that my boss, Hans Brug, who just talked to you at the first beginning, asked me, Marieke, we have to do something with behavior expertise, because coronavirus is all about behavior. So within an hour after this question, I was in touch with the director of the National Crisis Communication Team, who told me, well, there are these two guys somewhere in the Netherlands, and they're advising us, but we need to get something coordinated going. I didn't have contact details, so thanks to Twitter and LinkedIn, we were quickly connected. And that afternoon, we started a team. And we really started a team going. We had, at the first day, we had no formal position in the crisis structure, no name, no money, no staff. But this was how Marijn and Rijntjan started. The day after I got in touch with them, we had a kickoff of the Scientific Advisory Board. We realized at the beginning that we really needed top of the class psychologists, behavioral experts to get together and really share the knowledge and see how we would combine this knowledge. We had basically 30 behavioral scientists from our institute, from all different corners of the institute, working on climate, working on health, on different aspects, joining us and dividing tasks. How are we going to do this? And the three seniors, me and Marijn and Rijntjan, we basically had to drop our regular work and started going. Within 10 days, we had several intensive meetings in The Hague at the National Crisis Communication Team. With our professors in the advisory board, a theoretical framework for the COVID-19 prevention strategy was drawn up, and Marijn will go into this framework a little later in this presentation. We had a check on all the behaviors in a taxonomy for behavioral advice. Also, this point we'll address later. But also we needed, of course, the money. And I don't know how it is in all of your countries, but our government and also our research institute, research grant foundation really realized that this was so massive that research had to start fast. So within a few days, we had this research proposal written up, grant was granted, and we really started. And also the ministry supported us by really allowing us to get all these people we had working. So basically the growth curve of our unit was like this. We had to start going, and we really went for it because we had this major challenge. We really decided at the beginning that we had to contribute to make the COVID-19 prevention measures as effective as possible by making available state-of-the-art behavioral and communication science and expertise. And this is very much, we felt like adding to all the medical and virologist expertise, helping these behavioral insights, translating to government policy and communication. How really to get people follow the measures needed in preventing COVID-19 infections. Still always aiming at the health of the population. Not only looking at the infections themselves, but also at physical, mental and social well-being. It's the whole scope, because also we realized at the very start that if you want to have people following the measures, they have to be fit themselves. If they're mentally or socially or physically not well, it will be even harder to follow the measures to prevent the system, to prevent the infections. And now we're going more into depth into the theoretical frameworks.
Yeah. So basically, in a couple of weeks, we were from basically non-existence to a unit that was up and running, but still also designing the whole content strategy. And one of the things that we started with very early is you're not supposed to be able to read this. It's okay. It's just for the graphical. So it's also something that I saw a lot on Twitter and in news on the BBC and many other countries, that there was often criticism on how the behavioral recommendations were formulated. And they're often very much formulated from a virus modeling terminology. So basically the behavior of the virus, and maybe a bit less from the behavior of humans. And so one of the easy things for us to start with was to make this sort of taxonomy of the prevention behavior and recommendations that were provided. In the Netherlands, we could split the recommendations up, like hand washing and social distancing and not receiving visitors, etc. We could split them up in the recommendation for asymptomatic people, for symptomatic people, and for people with a symptomatic person in the household. And for these people in these different situations, there were different contexts. There was public space, there was the work environment, there was the home environment. So basically we made this structure and we listed all these behavioral recommendations for these different target groups in these different contexts in this taxonomy. And we started to rate all these behavioral recommendations. Are they sufficiently specific to help people figure out what they need to do, when, where, and why? Because a lot of the behavioral recommendations were, for example, wash your hands more frequently. Well, more frequently than what? And what at what time points exactly? So we started to ask all those questions, and we made all those behavioral recommendations much more specific. When you get home from being outdoors, before you prepare food, etc. And we also scored the complexity of all those behavioral recommendations. Was it always the same in any context? Like when you're sneezing, do it in your elbow. Well, you have to do that always, regardless of where you are. So that's quite a uniform recommendation. But some of these recommendations varying per context of per person or per age group, like social distancing. Other behaviors require preparatory behaviors, like when I need to use a paper towel, I first need to buy the paper towel, I need to carry them with me, and then I can use them to wipe my nose. So there were many characteristics in those behavioral recommendations that made them much more easy or much more complicated. And when they became more complicated, we added recommendations for advancing the communication about that behavioral advice. So one of the very early things that we did within the first 2 weeks that we existed is that we went through all the behavioral recommendations and we made them much more fit for helping human behavior rather than just the virus behavior. And that has resulted in quite a major overhaul of all the government websites and the core document on behavioral recommendations. So that was very early impact, sort of low-hanging fruit for the behavioral science. We also made a theoretical framework. It's not the most sophisticated theoretical framework. It's in Dutch. I'll explain it in a minute, but it was really there because it fits quite well with also the WHO frameworks, but also policymakers find it quite easy to access. And what you see on the left side of this figure is the more acute phase, where we basically use an upgraded health belief model version, like risk perceptions, response efficacy, social barriers, self-efficacy, cues to action. These were the things that we mainly focused on in the beginning of the pandemic. And then the next phase, phase 2, is about behavioral maintenance. And for that, we used an excellent systematic review on theories for behavioral maintenance. And they focus on motivation for maintenance, self-regulation behaviors, changing habits, your physical and mental capacity to sustain the behavior, and environmental factors, social and physical. So basically, we use this theoretical framework to organize our own work and to communicate with the professionals in communication at our own institute and at the government. Another part of our scientific foundation is that we used intervention mapping. Intervention mapping is a very systematic approach for developing behavioral interventions. And it's a 15-year-old framework, but it's been updated. It's in the 5th edition now, and it's one of the most widely adopted frameworks for developing behavioral interventions. And we made a brief version for this to help all the communication experts at the government and us communicate. And basically all our theory and all our creative expressions and all our goals and all our research ultimately end up in a table that basically links health outcomes to behavioral determinants, behavior change methods, and target groups. And so we had this step plan that we used since then for this purpose. And we have a very big research project, and here I can show you some of the results that we're gonna reveal quite soon. So this is sort of a sneak preview. At the moment, we're very much, so we have a very large survey, which we have amongst 50,000 people, and we run it every 3 weeks. And it has behavior and behavioral determinants, support for measures, and all these sort of things. And one of the things that we're focusing on now is the testing and isolating. Because in our data set, we see that about 11% of the people is symptomatic, scores yes for at least one of the symptoms that can be related to COVID-19. And less than 20% of those people actually stay at home. And we see that about 90% does shopping, half of them goes to work, etc. And then we measure their intentions to get tested. And we see that the intentions to get tested are quite high when people are asymptomatic, about 70%. But when people actually have symptoms, it drops to 28%. So it's sort of like when you realize what you actually have to do to get tested, and when you feel those symptoms, which don't feel too exotic, it's often just a runny nose or a cough that people are very familiar with from other conditions, then suddenly that intention goes down. And then from those people, we see on average that about 11% actually gets tested. So these numbers are way too low, and we're looking into, you know, valid arguments for not getting tested, etc. But what we want to illustrate here is that we've got a lot of behavioral data and determinants data that we're actually using to inform our decisions, communicate with the virologists, the epidemiologists, and government, and with the ministries, and it's really important part of our work. So our impact is, the impact that we think we have is on the side of the communication. So there's national campaigns. The Only Together campaigns that we're quite closely involved in. We've been very closely involved in preparing press conferences that have also been picked up by several more commercial, like Mobilization commercial companies that say, hey, look, there's a lot of behavior change techniques in these press conferences. There must be behavioral scientists in the background. And of course, it's not only us. There's a lot of experts around the Prime Minister. But we think we've got quite some messages across there. And we've been able to do quite a major overhaul of all the government websites. And then we've got some impact on policy and society. Part of that is through sharing our results. We work together with all the municipal health services across the Netherlands. We do our research together. So all our results land at a regional and local level. We've got regular questions from the Ministry of Health on face masks, social distancing, testing, etc. And we helped set up a behavioral expert team that looks at the track and trace app that might be launched at the end of the summer in the Netherlands. And we've got a lot of media exposure that we use to communicate with the general public.
Yes, and we also looked at specific groups because, for example, youth, we have this large survey Marijn mentioned already, and within the survey we noticed that especially mental health problems is an issue among the younger population and less an issue with the elderly population. We've asked questions about how do you feel your mental health is compared to before the pandemic started, and we were quite well shocked at how big the impact is with the age group between 16 and 24. So we have this parallel to the survey. We have also an interview team, and the interview team every 3 weeks parallel to the survey, we have them interviewing specific people. We have 15 people being interviewed every 3 weeks. So for them, we see a whole, well, how they develop through it. But for youth, we had also a specific interview group to really get more into depth how hard it hits them, in what aspects it hits them, and something we, well, it is a worry. We see them already getting much better because of all the less social distancing for them. High schools are starting up after the summer. They've been starting up already a little bit. But we wanted to also share our knowledge within among this target group together with the National Youth Council, together with some specific youth care workers. And we did so in a webinar yesterday. And on the picture you see the final guest who did a rep with all the results of the youth impact survey. So we really try to feed back not only to the government, but also to the professional community dealing with specific matters and challenges. Additionally, currently in the Netherlands, and perhaps I suppose it's in many countries the same, very much a big challenge is how to maintain the social distancing. We see a lot of people reporting also to us that it's very hard to keep this 1.5 meters distance we have in the Netherlands within supermarkets, when you go grocery shopping, when they go to work, it's very hard. And now also with people more having guests at home or going to a party, it's quite a challenge. But also it's the figures now with isolating and testing. That's something we're still debating on, but it's all looking forward to preventing the second wave. At the moment, this infection rate is very low, but we don't know what's coming.
Yeah, so in sum, the problem is the virus, but the solution is in human behavior. And we were not part of the core disciplines in the Dutch initial response, but we are now almost fully, And then there's a huge amount of knowledge and expertise that we notice that can be activated very rapidly. We have this scientific advisory board of very dedicated people, and within 24 hours, we basically have sort of what almost looks like a consensus when we want to address something. So it's just been absolutely amazing, and they activate their whole institutes and research groups behind it to basically all feed in nighttime, in weekends. It's just amazing, the response. So. And we've got a momentum for behavioral science now, and we're looking at how we can maybe consolidate and integrate this in future structures, also for other crises than COVID-19. So think about health and climate, etc. So it's really a springboard maybe for the discipline. So one, I know the time is up now, but one briefing, the results that we showed for the testing, the figure with the percentages, it's I need to say that it's preliminary. We're wrapping that up. It's not yet ready for citation, and it needs to be seen in the context. But we wanted to give this sneak preview just to illustrate the type of data that we're collecting.
But all the data we've been brought out so far from our surveys can be found on the English pages of our website. So up till the 4th measurement, which dates from 3 weeks ago, it's online now, and the 5th measurement is going on right now. Within 3 weeks, it will be published in English as well. So
that's
far,
great.
that's
Thank you very much. So we've just had one question from Lydia Lazari, which is about the behavioural determinants, and can you elaborate on what those are? So when you're saying behavioural determinants, what are you referring to specifically? She also said congratulations on the
so we're measuring five core constructs. We're measuring self-efficacy. So how easy or difficult people find it to perform the different behavioral measures. We look at response efficacy, how effective people think the measures are in mitigating the risks. We look at various properties of risk perception. We look at the perceived threats, the emotional threats that people experience from the virus. And we're looking at social norms, injunctive and descriptive social norms. So basically, what do I see others in my environment do, and what do I feel that people think I should be doing? So these are some of the key things. And then in other parts of the questionnaire, we've got trust and procedural justice and support for government policy, etc. So and we've got more emotional social well-being in another part. But the exact behavioral determinants are these 5.
And are those part of the theoretical framework that you're using? Is that an integral part of it, or have you had to combine? So if people wanted to use your framework, would it include those factors?
Yeah. So the questionnaire would be too long if we ask all the questions to everybody. So we have 3 sub-cohorts in our questionnaire, and they all respond to the behavioral measures, but then 1/3 responds to the well-being, 1/3 to behavioral determinants like the risk perceptions, and 1/3 to the support for government policy and procedural justice. But we can relate them all to the behavioral the behavior patterns that people are showing.
Excellent, thank you. So what I'm going to do now, though, is move on to the next presentations, because I think it'll be nice to have an interchange between the two. So if I can ask Gaël Lièvre to just get ready to start presenting on the activities of the French Behavioural Insights Unit, and is going to talk about France's interministerial directorate's work on this. Gaël, can I pass over to you now?
Hi, can you hear me?
Yes, indeed.
Perfect. I'm just setting the slides. Perfect. Good afternoon, everybody. Thank you very much for inviting me to present the work of the French Behavioural Insights Unit at the Interministerial Directorate for Public Transformation in France. I'll give you an introduction of the work of the Behavioural Insights Unit, so how behavioural insights was applied in time of COVID-19. So here is a presentation of the team. The team is made of 5 to 6 people. I had the chance to intern in this team until very recently. And in most
you seem to have gone quiet. We've lost your sound.
Can you hear me?
Yeah, we can now, yeah.
Oh, I think my internet connection might not be very stable.
Carry on, it's working now.
Great. So yeah, I was saying that on most projects, the team works with 2 main providers, but of course during this very special COVID period, due to the very short deadlines, those providers on most projects were not involved. So the work of the French behavior can mainly be divided into 2 categories, 2 broad categories. There was one part of the work which focused on improving communication by providing insights about behavior during COVID-19. So the team worked on recommendations regarding confinement, regarding deconfinement, and that was an important part of the work, we supported the so-called Mission Castex, which was in charge of the national strategy for deconfinement in France. And also some recommendations were produced regarding the government's website and official communication in general. And the second part relates to more specific projects, but I'll come back to it in the second part of the presentation. So regarding the improvement of communication and the provision of insights about human behavior during the goal was really to give insights about human behavior, human cognition, and decision-making in a very wide range of settings. So for instance, the team was involved in producing various kits regarding education, regarding public transportations in times of COVID, regarding the associative life and life at work. So if I take the example of education, some qualitative interviews were conducted with teachers because in France in this time, most of the pupils would not be at school, but some of them would. So to extend the schooling of pupils, the team interviewed teachers to get their perception, the perception on the barriers, on what was difficult, what they could manage, and how it went for them, to try to help the extension of this schooling. And other recommendations were produced on, again, a very wide range of topics. For instance, elevators, how to limit the risk of virus transmission in elevators, also regarding summer holidays, and so on. So really here, the aim was to provide general recommendations and operational inspirations. And throughout this work, this different work, we tried to apply some behavioral principles that are backed by the literature. And I'll go through them very quickly, but some important principles we tried to apply was to use as many visual aids as possible, not to provide too much information, and to be clear in telling people what to do and what not to do. And the aim of those first three principles was really that humans have attentional limitations. They can only process so much information, and especially in this period, people are overwhelmed by the quantity of information they would receive. So we really try to make it simple, clear, and to aid people with the quantity of information provided. Then another principle was to make the danger visible, which is especially, I think, important in this case, because COVID is invisible as opposed to other threats. And we also tried, whenever appropriate, to call to duty rather than personal interest, because some studies have shown that, in fact, calling on protecting others, the protection of others, yielded even higher adherence to social distancing guidelines than calling on personal interest of protecting personal health. So that was also something that could be used. We also tried to inform about social norms, especially the less visible ones, because again, one particularity of this period was that it was actually very easy to see people who would not respect the guidelines, the social distancing guidelines, for instance, or that would go out when they should not. But in fact, it was much harder to see all the people who respected the guidelines. So that was something to emphasize. And other principles were not to be reassuring when the situation is not, to actually be transparent about the uncertainty and staying humble, relying on the trust that people have in science. Also, when appropriate, rely on influencers and the power of communities, and remember to take into account the fact that there are important differences in context. So the situation was not the same depending, of course, on professional background, social background, locations, and so on. So that was for the first the second category related relates to more specific projects. And I'll go through some of them. One of the projects that the team was involved in concerned nursing homes. So, can you hear me? The project concerned nursing homes. And for this project, we conducted phone interviews in order to understand the context in highly exposed nursing homes and avoid similar scenario in others, because of course there were many cases and that was a major challenge during the crisis. So qualitative interviews were conducted, notably with staff at nursing homes. And from these interviews, the team got some interesting insights. The first one relates to overcommunication. And I've mentioned before the attentional limitation of humans in general. So in response to this insight, one of the recommendations that the team made was to maybe send less information, only twice or once per week. But the problem with this was that less communication can actually...
Gail, maybe if you turn off your video, we keep losing you. Can you just turn off your video to see if that improves your sound?
You can't... right. Can you hear me better?
Yeah, we can hear you now. Yeah, carry on, please. Sorry.
I'm sorry about this. So I hope you didn't lose too much of the presentation. I was talking about this project in nursing homes, and one of the insights that we got about not engaging in over-communication. And I was saying that sending less information was an option, but there was this risk aversion to miss on some information. So an alternative that the team recommended was to put all the information on the platform and occasionally send the most important elements. Then we got over insights, notably regarding habituation and cognitive fatigue. So cognitive and in fact physical fatigues as well may impair decision-making, and they may lead to more impulsivity, more impulsive choices, and even some complacency after working many hours. So one of the recommendations that we made was to designate one ultra-vigilant or some ultra-vigilant reference every day, and to rotate, alternate the position, alternate these roles. So we had of course, over insights regarding risk exposure and risk perception. But I think in so yeah, briefly, we also had some other projects regarding consumer protection to inform citizens on how to avoid new types of frauds that have emerged during COVID-19. For instance, false advertising or false screening kits. And another project about physical activity. So I mentioned the providers that the French Behavioural Insights team has. This project was actually conducted with one of our two providers, the Behavioural Insights team in the UK. And the aim of this project was really to encourage French citizens to practice physical activity during confinement, so when they had to stay at home. And for this, a website, a platform, an online platform was developed. It's called Bougez chez vous, exercise at home. So if you want, you can check it. Unfortunately, for non-French speakers, it's in French, but it's still there.
If you can just sum up now, just so that we can get on to some discussions.
Yeah, sure. So I'll just summarize by talking about the team's strengths and acknowledge the fact that the team had really useful, really precious ties with other international behavioral insights team, and also received the support of of the French Behavioural Insights community, which work with researchers in behavioral science, which worked with us, especially to prepare deconfinement, and also the flexibility and reactiveness of the team. And this is my last slide. I think I thought it would be worth mentioning the specific challenges of this period for behavioral science in general. Of course, I think behavioral science is critical, it's essential, and it's a major part of the issue, but we should not overlook structural challenges, especially at the beginning of the crisis, where we faced shortages of masks and of screening tests. And lastly, there's also a compromise when you're in a crisis between an immediate response and the scientific rigor. So in behavioral science, in the team, we always try to perform rigorous evaluation of the interventions. And in many projects that we had outside of COVID, we try to perform randomized controlled trials. But of course, in time of crisis, this is much more difficult because of time constraints. So to mitigate this, we try to consider the scientific literature when possible. And in some other projects in general, we had to adapt. So for instance, in nursing homes, when we had to deliver a synthesis within 2 days, we conducted phone interviews because these were less time consuming. And
okay, thank you.
And yeah, so I think that's a good conclusion. We can stop here. Thank you very much.
Okay, thank you. And I think that nicely complements the first presentation, because it's the link between the behavioral insights and then the communication of the desired behavior changes that is important. So I think you've drawn out the fact that we draw on the insights work, and then you nicely introduced at the end the importance of evaluation as well, to assess the impact of what we're communicating. So for the sake of time, and actually to bring the discussions together, we have one pending question on sort of digital surveillance apps, but I'll go on first to ensure that we hear properly from Pierre Auwitsen, who's going to talk about psychobehavioral surveillance systems. He's from Santé Publique France. So Pierre, can you give your presentation, and then that will give us sort of 10 minutes at the end for a quick exchange.
Thank you. Do you hear me?
We do indeed, thank you.
Okay, so I have shut down the video to have more, so yeah, you hear me better. So thank you for giving me the opportunity to share our work. So I'm doing this presentation, but it's the work of a team, and I've put other names on the first slide. Next slide, please. As been said before, behavioral is critical, so we must track behaviors and the feelings of the population. And it was done during the H1N1 and SARS pandemics. You cannot only count cases, hospitalizations, and death. You must do more. So we need a kind of psychobehavioral surveillance. So we did put one in place. Now, come back to the yes. So we have done 12 waves now. Because of the lockdown, we couldn't do phone surveys because the platforms were closed. And we could not do random samples because we couldn't have access quickly to the national database of taxpayers. So our survey are quarter samples, and we did a sample of 2,000 each week, then every 2 weeks, and then we will go on every month. Next slide, please. So you can see on that slide that the COVID-19 has the highest level of perceived severity and the highest level of expressed worry than all the previous outbreaks and pandemics on the French territory. So this is very special. It's a very special pandemic. Can you put the next slide? Thank you. So here you can see the trends on our 11 waves of avoid shaking hands and kissing, keep 1 meter distance, wash hands frequently, cough in your elbow, use disposable handkerchief, wear a face mask in public. And as the people were applying very highly, and we had a ceiling effect, not a roof, a ceiling effect. So previous slide, please. No. Yes, please stay on that one. Yes. So as you can see, we started the survey just after the lockdown, and then you have the end of the lockdown, and you can see that all the measures are declining. All the measures are declining, even if they are stabilizing at the end. But what happened was that the population started using face masks even before it was recommended by the official recommendation. And you can see that the social distancing and the face mask are symmetrically going one to another. Next slide, please. So this is the mental health, and we have measured life satisfaction. We have measured sleep disorders, depression and anxiety, and life satisfaction and sleep disorders and anxiety was very higher than and outside time of pandemics. And you can also see that the mental health has improved. Mental health has improved even before the end of the lockdown. And that was because people were getting used to the situation. Next slide, please. So we did a linear regression model, and the 6 models that we did included the influence of the following categories of variables on preventive measures. And we did the models with each category alone and together. And those categories are socio-cultural variables like gender, age, socioeconomic status, psychosocial variables like trust in the institution, anxiety, do you have social support, and the cognitive variables of the model that we spoke before, like perceived severity, perceived behavioral control that we call self-efficacy, perceived barriers of preventive behavior, etc., and subjective norms. Next slide, please. So we saw differences. The rate of compliance was very high in the whole population, but men and younger participants were less compliant. People who have trust in the institution were more likely to comply. Those who have a higher level of anxiety were more likely to comply, and those who had lower economic status were less likely to comply. Next slide, please. But with the overall model, when we introduce all those variables in the same model, we saw that the socio-cognitive variables improved the explanatory power of the model, and especially the 2 strongest were the perceived effectiveness of the prevention behavior. And the second one that was, we did that study on the first 2 waves. And the subject, previous, yes. The subjective norms were by far the most influential determinants of compliance in the overall model in both surveys. Next slide, please. So when the social cognitive variables were included into the overall model, the regression coefficient for both the social cultural, like the trust, or the psychosocial factors like anxiety, were either substantially lower or no longer significant. In the case that these variables were more indirect than direct predictors of the compliance with recommendation. Next slide, I think it's the last one. So we conclude that rather than appealing to fear of punishment or harm, it seems better to emphasize on positive norms according to our findings. And in our study, we also see that people overestimate the death rate of SARS-CoV-2 infected people. Nearly half of the population think it's 5% and more, previous please, and 20% think it's 20% or more. And what we have introduced in a modeling Institut Pasteur is only 0.25%. So the population doesn't know, the person do not know that very low level of death rate. They surestimate this. So what will happen when the population will know the exact figures, and what will be its reaction to the proposal of a vaccine? So thank you for your attention.
Thank you very much. And that again moves us nicely on to a different aspect. One specific question, did you look at ethnicity and any differences in the perceived risks? In the UK, we've noticed significant differences in the impact of COVID on different groups. And this has coincided, obviously, with the George Floyd incident and widespread recognition of structural inequalities. So there's potentially factors there which may influence perception of risks linked to ethnicity. Did that feature at all in your survey?
We cannot ask those questions in our surveys, but for the mortality, we are introducing the ethnicity. So we are building a system to answer the question: are immigrants more sick or dead than we don't know yet, but we are building the system. And we are not allowed in France. We are not allowed to ask, "Are you a black person?" You cannot ask that.
Oh, really? Okay. Okay. In fact, somebody on the line, Tim Chatborn, I think, is on the line from PHE. Tim, could I bring you in? I mean, having heard the presentations, is there anything that you would add to this discussion? I think you have the ability to speak.
Hi, thank you. Yeah, no, some really interesting stuff, and I particularly like that last analysis that you've done. I'm not sure if we've really tried to do the same thing here. We have had sort of daily polling and multiple polling every week, similarly, but I don't think we've done that type of analysis on it. Similar work, I think, going on in terms of using behavioural science to contribute to guidance and interventions such as contact tracing, and to enhance contact tracing processes and testing processes, and advise some of the work like that. One thing I think which is a bit new on is trying to actually, as I kind of put a question in there, trying to think about behavioural surveillance at a local level. So rather than the sort of 2,000 people nationally, how can we try and get figures of sort of adherence to isolation and testing uptake and social distancing and things like that would maybe give us an early warning system to more rapidly enable local lockdowns?
Thank you. So maybe that's a question that can go back to our panel. So if I can go back to Marikan and Marjin, any particular additional comments, having heard the other presentations? Have they prompted any thoughts from you?
Well, one thought is I wish we had 11 measures. So that looks very interesting. I think we're seeing partly the same patterns in the social distancing and some of the hygiene measures that they're declining over time, together with the figures and the threats that people are experiencing. We've got face masks are very newish here. But we think we're seeing also an increase. So the support for that is also very low initially, like only 30% of the people thought it made sense to use them in public transport. And but the next measure, it was already 10 or 15% higher. So it actually seems that it's the only one that is going up. So who knows, we're getting the same type of patterns that we were just seeing, where it's just the face masks are just going to go in the opposite direction of all the other behaviors.
And there is a question there, I mean, maybe to all of the panel, because it's only in the UK we began to see behaviours changing before advice came out. So we'd seen some reduction in the incidence of new infection even before we'd introduced lockdown measures. So people were adapting behaviour on the basis of information they received. Is that a feature you've experienced in Holland and France?
I don't think we have it in the data, so it would be more speaking from personal experience than anything else. So.
Well, it was a bit like we had, from the medical perspective, there was no advice to close down the schools, but there was this big, common sense among the general population and among a group of medical specialists. They really stepped forward and really were asking basically to close down schools. So we had also forces coming from outside the crisis organization to really put forward more measures. That something did happen.
And a lot of people were not bringing their kids to school before the schools actually closed. Yeah, that's right. Yeah.
So about the face mask, the population is not used in France, not used to use face masks, but they start using it before the advice was given. because there was a controversy between experts about the face mask, and there still is. But the population, I think they saw interviews or reportage from other countries, and they said, okay, why they do it in Korea, they do it in China, why couldn't we do it in France?
Yeah, and in the Netherlands the same. Face masks are only compulsory in public transport, but when you walk around on the roads, you see more and more people wearing face masks. Also because of now people are allowed to go more outside. You see a specific group who's going less outside, who are getting more afraid because they're vulnerable. So they feel they're more confined to their homes. And now with more people going outside, so there are different groups reacting differently to making it.
Does that relate to, so in Pierre's presentation he highlighted at the end the excessive risk perception that some people have. Do you see a distinction, because you've looked at different subsets of the population, young people versus old, have you noticed any difference in the risk perception between different groups, and does that impact on the behaviors?
We have to look at it. We have the data, but we didn't dig it. We didn't have even time to work. We had a new survey each week, so we could not analyze everything, but we will do it and send it to you. Very good. And Majid?
Yeah, I was hoping I could escape this one because my answer is sort of the same. We've been in this extreme pressure cooker, and we haven't been able to go as deep in the data as we would like to. But at the moment, we're running longitudinal analysis and at the subgroup level, and we're starting with how socially active people are and how adherent they are to the prevention measures. And then we'll move to well-being and determinants and support for the measures. One of the things that we do see is that there's an age gradient in terms of social contacts and adherence to the measures, where in general you tend to see that younger people are increasingly socially active and are less adherent, it seems, to some of the, not all of them, but to some of the prevention policies, and yeah, that makes it a little bit more risky for them.
Okay. I'm afraid we're now at, I don't know whether there's any flexibility to extend the time, but just in case there isn't, I want to give my huge thanks to all of our presenters on behalf of IANPHI. I mean, this is a fascinating discussion, and it's very nicely, the presentations all link very closely together. So we've seen that there are theoretical frameworks, there's a solid evidence base for them, and that but there's also the link between the behavioural insights and the communication is key, as is evaluating the resulting behaviour change. But the Gail gave the very nice presentation of some of the principles that need to underpin communication, which I think was incredibly useful. And Pierre very nicely summarised at the end some perceptions of risks and the importance of evaluation. So I think the four presentations, four presenters together have told a lovely story about the value of behavioural insights and the importance of effective communication and the style of that, and the need for robust evaluation. But you've all also highlighted you're working under huge pressure. There's a huge amount of data there, and there's a lot we'll be able to analyse, but we don't have all of the answers yet. But fascinating presentation, so thank you all very much.